Scrubs and Clogs, a podcast brought to you by the Apprentice Journal, Faculty of Medicine, University of California, where experts scrub in to bring you the very latest in surgery.
Welcome to Scrubs and Clogs, the podcast brought to you by the Department of Surgery, Faculty of Medicine, University of California. Today's topic is, did the appendix say, if in doubt, cut me out? We'll be discussing some interesting facts about a very common disease entity. To discuss about appendicitis, appendix and its complications, I have here with me today Dr. Sumudhu Kumarage, the head of the Department of Surgery, Faculty of Medicine, University of California. Welcome, sir. First of all, we all talk about appendicitis, the appendix and its complications. But could you briefly discuss the anatomy of the appendix, where it is located, and what are its functions, if at all?
Thank you, Pramod. When you consider the anatomy of the appendix, appendix is situated in the right iliac fossa, and it's like a diverticulum arising from the cecum, but it has its all the layers of the bowel. And the base of the appendix is more constant, but the tip of the appendix is very variable. It may be situated in the pelvis, it may situated parallel to the cecum, behind the ileum, behind the cecum. So it can take many anatomical places, and the length is also very variable. But the tip of the appendix for clinical, the base of the appendix for all clinical purposes is fairly constant. It is in the McBurney's point. So anatomically we use that point to locate the base of the appendix. And then you asked about the function of the appendix. Conventionally, we believe that it doesn't have any function, and we think that it is a useless organ which can be sacrificed. But very unlikely human body has got an organ which doesn't have a function at all. So now we believe, and it is disclosed that appendix also subserve some functions. So one important function of appendix is it's a lymphoid. There are lymphoid follicles, and so it has important immunological functions. It is a very important organ to maintain gut immunity, to maintain luminal barriers. Appendix plays a role, and further, it acts as a reservoir for gut microbiota, and that will help to boost healthy microbiota after gut infection. And some have shown that it has an endocrine function as well, which is mainly during neonatal period.
Right, so this blind ending tube, which was traditionally called the vermiform appendix because it does not have a definitive anatomy. And traditionally it was thought that it does not have any specific functions, but with advancement in our knowledge about the human body, it may have some important functions in the human GI tract. So appendicitis is the commonest surgical problem that is managed in accident and emergency services worldwide, I would say. So we would like to know what actually is appendicitis and how does it commonly present in the clinical practice?
Yes, acute appendicitis is the commonest pathology occur in the appendix. And appendicitis or acute appendicitis is an acute inflammatory condition. So like acute cholecystitis, acute pancreatitis, the same pathological changes occur in appendix as well. The injurious agent leading to this is an infection, and usually this is followed by an obstruction to the lumen of the appendix, probably due to fecolith, sometimes enlarged lymphoid follicles causing obstruction. So more than 80% of the appendicitis is following obstruction. Second thing you asked is the clinical symptoms. So you get all the features of inflammation. So they get pain. So when this visceral pain visceral pain is very non-specific. So usually initially they tend to feel this pain as a diffuse abdominal pain or periumbilical pain. And later it may localize in the right iliac fossa as the parietal peritoneum is irritated. It is associated with nausea, sometimes vomiting, if at all mild fever, and significant loss of appetite and feeling of unwell. So these are usual clinical features of acute appendicitis. But typical clinical features are there in about 50% of the patient with acute appendicitis.
Right. So one of the marked features is the right lower abdominal pain or the pain in the right iliac fossa. But are all right-sided abdominal pains appendicitis? What else can it be?
As I said, these were the sort of features of inflammation occur in the appendix. So any structure in the right iliac fossa or right side of the abdomen can give rise to these symptoms. So things like gynecological pathologies, ovarian pathologies, twisted ovarian cyst, even ureteric colic may mimic acute appendicitis. Pathologies in the cecum, inflammation in the cecum, terminal ileum also give rise to similar symptoms. And enlarged lymph node, there are a lot of lymphoid follicles in the appendix, around the appendix. So mesenteric lymphadenitis also can give rise to symptoms similar to appendicitis.
Right. So here we have an organ without a definitive anatomy and having very non-specific symptoms when it gets inflamed. Must be posing a very difficult challenge when it comes to clinical practice. So as a clinician, what are the minimal diagnostic investigations required for you to come to a diagnosis of appendicitis?
Appendicitis, in all practical purposes, is a clinical diagnosis. Other investigations are done to support your diagnosis as well as to exclude certain other possibilities which we may consider in a given patient. So, clinical history and examination is the most important thing in order to come into a diagnosis. And most of the time, this is more than enough to proceed with a definitive treatment also. But nowadays, clinical practice, we need sort of more confirmatory evidence. So we would like to confirm that there is an inflammatory process going on. So we do inflammatory markers, white counts, ultrasound scan. These three and the urine analysis are the four common investigations we do in most of the patients. And the last two, urine analysis and ultrasound scan, is done mainly to exclude another pathology. Maybe ovarian pathology, gynecological pathology, ectopic pregnancy, right? Ureteric calculi, urinary tract infection. So these are the minimum or not minimum, the common investigations we do in order to confirm or refute other possibilities of diagnosis.
Right. So there are no specific diagnostic tests available to diagnose acute appendicitis. What about the new imaging modalities like CT scan or MRI scans? And also, we have heard about scoring systems in acute appendicitis. What is the role of these when it comes to diagnosis?
Yes. Now, especially the CT scan has a very high specificity and sensitivity in diagnosing appendicitis. True, it is higher than the clinical sensitivity and specificity. But can we afford to do CT in all patients suspecting of having appendicitis? And this is a disease which occurs in reproductive age. And if we subject all of them to CT, one issue is the cost, other issue is the radiation. So the most specific and most sensitive test, though it is CT scan, we may not be able to use it freely to diagnose acute appendicitis. But when there is a doubt or when there is sort of suspecting complications, we may have to do imaging investigations.
Right. And do we commonly use these scoring systems nowadays?
Scoring systems has been used before the imaging came into place. So these scoring systems are taken into account not only the clinical features but certain biochemical parameters as well. So based on that, the specificity of the diagnosis was increased. But nowadays, the imaging has imaging play a major role when we are in doubt and to increase the specificity of diagnosis.
Right. You mentioned briefly about complications in appendicitis. So if a patient gets delayed to present to a hospital, what are the complications that can occur due to acute appendicitis?
When they get delayed to present or the treatment, they may develop appendicular mass. If you don't act quick enough, the body is trying to conceal this problem or cure this problem. So very minority of the patients, appendicitis settles on its own. It can be increased by giving antibiotics. We may probably talk about the place of antibiotics later. But if patient is not given antibiotics, still the body is trying to conceal this problem. So the body tries to cover this up. The omentum, which comes and wrap around the appendix, not only the omentum, the surrounding small bowel also wraps around the appendix. So the inflammatory process is confined to a small area. So after that, still it continues. The blood supply, the problem of acute inflammation is the thrombosis of appendicular artery. If this happens, the appendix undergo gangrene, perforation, which may lead to abscess formation. Most of these abscesses are concealed abscesses, or there is no free pus or perforation. But sometimes they may perforate into the peritoneal cavity, leading to peritonitis.
Right. So now we've discussed about the presentation and the possible complications. Let's move on to the treatment part. Simply, what is the treatment for acute appendicitis?
The treatment of choice for acute appendicitis is appendicectomy. Today's context, most of the appendicectomy is done laparoscopically. So if I say laparoscopic appendicectomy, it is correct.
Right. So the treatment of choice is surgical, it's laparoscopic appendicectomy. Can uncomplicated appendicitis be treated with antibiotics alone, like you treat a cellulitis? So what is the evidence behind treating appendicitis with antibiotics?
Yes. Of course, there were few large recent studies to indicate that there is a place for antibiotics in the management of acute appendicitis. We have more potent antibiotics, antibiotics which penetrates to inflamed tissues rapidly. So today's context, there is a place for antibiotics. But before that, the law, many years ago, also people used antibiotics to treat appendicitis. Sometimes without diagnosing appendicitis, even after diagnosing appendicitis also. But there are not much consensus regarding this management. So wherever it is possible and accessible, in my practice, I will do appendicectomy. But the use of antibiotics is restricted in my practice, mainly in patients who don't have complicated appendicitis, and when there is a risk of doing surgery and the surgery is not possible at that time, we probably start with antibiotics.
Right. So surgery is the mainstay, but antibiotics also can play a role in patients who are not fit enough or have a high risk to undergo surgery. And also, I think with the use of antibiotics, there are more recurrences, and the recurrences can be more complicated because of adhesions or mass formation during primary antibiotic therapy. So we discussed about complications in acute appendicitis. Would you still offer surgery when they have a complication, or would your management differ when there are complications of acute appendicitis?
Surgery for complicated appendicitis can give rise to more complications. So, complicated appendicitis should be managed cautiously. Certain complications can be managed without surgery. For example, appendicular mass. If there is appendicular mass, if you try to do surgery, you may do more harm. He may end up in enterocutaneous fistula, bowel injury. So the most advisable thing is to manage conservatively. If there is an if there is an appendicular abscess, of course that needs to be drained. Today's context, we have less invasive modalities to drain these abscesses. You can drain under ultrasound guidance, or you can use laparoscopy and drainage. If appendix is easily coming out during that process, you may do appendicectomy, but most of the time you don't have to do appendicectomy. Your main intention is to drain the abscess. But if there is a pre-perforation and peritonitis, there is no conservative management. You have to go in, you have to clean up the abdomen. If appendicectomy is not your primary objective. If it is easy, you may do it, but it is not mandatory.
Right. Often in clinical practice, we see patients taking oral antibiotics, either over the counter or they've been treated wrongly with oral antibiotics for right iliac fossa pain. How does this affect in the management and the outcome?
Antibiotics may mask symptoms. And I said antibiotics has a place in management of acute appendicitis. If you diagnosed them having acute appendicitis, you may start antibiotics that is accepted. But at the same time, there's a problem. Without doing appendicectomy, it is very difficult to confirm your diagnosis unless you do a CT scan. And clinical diagnosis is about 80% correct. So there's a significant proportion of patients are getting antibiotics unnecessarily. So they may get resistance, and in case when you have to use antibiotics, they may having resistant organisms. So haphazard use of antibiotics is not accepted.
Right. So you should not be using oral antibiotics if you are suspecting acute appendicitis, because that may mask your symptoms and cause more problems when it comes to clinical management, and also cause resistance to antibiotics. Now, moving on to a bit of a different area, the appendix have been linked to inflammatory bowel disease, and we see so many studies being done in this regard to both Crohn's disease and ulcerative colitis. Could you briefly elaborate on this link between the appendicectomy and the risk of developing IBD and also vice versa?
Yes, this is a very controversial thing, and recently very large-scale epidemiological studies have shown, especially initially for the ulcerative colitis, they have shown that patients who had appendicectomy, the incidence of developing ulcerative colitis is less. So the argument is it protective? Right? So should we do prophylactic appendicectomy? Ulcerative colitis is not a disease very common in the community. So prophylactic appendicectomy is not coming into practice anyway. This is an observation, and it has not proven also. The large cohort of epidemiological studies, they have shown the incidence of ulcerative colitis is less patients who had appendicectomy during their childhood. Crohn's disease, so based on that, people were trying to look at the incidence of Crohn's disease in relation to appendicectomy. So those studies showed the inverse relationship. So those who had appendicectomy are more prone to get Crohn's disease. And there were sort of those who had appendicectomy. Now this correlation is less when you had appendicectomy in your childhood. And there is a gender variation also. The females has less correlation. So, so it is not very sure whether they had the appendicectomy was done for mild Crohn's disease also. So there are a lot of controversies, but the relationship we know, the patients who had appendicectomy had a less chance of developing ulcerative colitis, more chance of developing Crohn's disease, but exact relationship is unknown.
Right. So the link between appendicectomy and the inflammatory bowel disease is controversial. We still do not have a verdict there. Lastly, now when we do an appendicectomy, we send the specimen for histology. Is it important to see the report afterwards, since we have already diagnosed acute appendicitis? If so, what are the benefits of looking at this?
Yes, it is very important. This is a clinical diagnosis. That's why I said sort of when we treat with antibiotics, we don't have a final diagnosis. That's the main drawback in managing appendicitis with IV antibiotics. That's my personal belief. One important thing is sort of the appendicitis is not the only pathological problem which appendix get. You might rarely get mucinous carcinoma of the appendix. So it's parasitic infestations of the appendix. Right? So if you send it for histology, you may recognize these things, and they may in its early stage, and it may be curable also. So it is very, very important to send. Even the appendix is inflamed, you know for sure that it is inflamed, send for histology. Other more common than carcinomas, mucinous carcinomas, the inflammatory bowel disease, Crohn's disease, you may diagnose in the histology of appendix.
Right. So we have discussed today the presentation of acute appendicitis, the clinical diagnosis, the different modalities available for that, the complications, management of simple acute appendicitis, and also the management of complications, and also some of the controversies that are surrounding the appendix and acute appendicitis. So I would like to thank Dr. Sumudhu Kumarage, Head of the Department of Surgery at the Faculty of Medicine, University of Kelaniya, for his time to have this chat with us. Thank you all, and this is Scrubs and Clogs, the podcast by the Department of Surgery.